huge welcome to everyone. I'm April Salama. I'm one of the medical oncologists at Duke, obviously with an interest in melanoma and ocular melanoma, and it's a real privilege to be here, to have been asked to host this event with my colleague, Dr. Materin. I think we have a wonderful program here for you all today, and again, thank you for coming, and you know, this is a true partnership, and we're really appreciative that you're here.
Well, let's get this started, okay? Well, first of all, if we were in Argentina, Saturday, 8 o'clock will be considered Friday night. So, apologize, and I'm from Argentina. If you don't understand my English, I have several translators here that I've been working with for several years, okay? My presentation is to talk about where are we coming from, where we're at today, and where we're going. Uveal melanoma is the most common primary intraocular malignant tumor in adults. It represents 3 to 5% of all melanomas in the body. The incidence is between 5-7 cases per year per million in the United States. The average age is 55, 60 years old, mostly in white people, and the most common places that it gives metastasis is to the liver and lungs. When we see a patient with uveal melanoma, what are our priorities? Life is number one. You may say, well, that makes sense. Oh, you won't believe that other people, many people, they think, oh, well, I'll lose my sight, well, I'll lose my eye. So that's when we need to restart the conversation, and we tell the patients, we need to take care of your life first, your eye second, and vision. We are the only ophthalmologists that vision is our third priority. Traditionally, uveal melanoma has been classified in small, medium, or large. Now, back in the day, 20, 30 years old, we didn't know why some patients will have metastases and some patients will never have metastases. So now we're going backwards. We're going into the past, and let's do a little bit of history here. Let's talk about the past first. The first article I found about uveal melanoma was dated in 1891 by Dr. Reed in Glasgow. Henry Stallard, he was the pioneer in the plaque treatment for uveal melanoma. Did you guys know that? I found that was interesting. So he started with the plaques in the 30s. So when he was running, he was a medical student. And then he presented this paper in 1966 after treated 100 patients with uveal melanoma with a cobalt plaque. That was the start of the brachytherapy for us. So let's talk a little bit about uveal melanoma, past, present, and future, the way I see it. So this is me, how I live this uveal melanoma. In the 80s, I was still a medical student, the main concern was diagnosis. Is this melanoma? Is this not melanoma? Let's wait for growth, et cetera, et cetera. So there was a challenge in diagnosis. COMS, the Collaborative Ocular Melanoma Study, started in the 80s, and one of the arms for that study was, what is better, plaque or enucleation? Some of the doctors knew that plaque and enucleation had the same life prognosis, so some of the centers abandoned the COMS, but lots of reports came from the COMS. In the 90s, we had a second tool to treat patients, and that was the TTT laser. So we have very high enthusiasm with the TTT only, and there were some problems 5-10 years later. So today, the TTT laser is used mainly as an adjuvant treatment for the plaques. We've learned the risk factors for growth, and I want to be clear about this because many of you and many doctors, trainees, etc., they think that the risk factors for growth is for all melanomas or any pigmentation we see in the eye. No, this is for small melanocytic choroidal lesions. And the risk factors for growth means, okay, what are the chances that the lesion I'm seeing has to grow? Why? Because most of the time growth is considered melanoma. But that is for small tumors. The reports from COM started to show up, and there were more than 40 reports from that prospective trial. In 2000, well, we started trying to save vision. How? It was like, first of all, was steroid injections around the eye. Then we started to use the steroid injections within the eye. And there were improvements in vision within a week, but it didn't last more than 6 months. So sometimes it's used, sometimes it's not. These days, we don't use that as the primary treatment to preserve vision. And we started to do biopsies. The first time I've heard about the biopsies was when I visited Dr. D'Amato in Liverpool. And he was telling me, well, Miguel, there are some good melanomas and some bad melanomas. And what they use in Europe is the chromosome analysis. And at that time, it was the chromosome 3 analysis. Monosomy 3, worse prognosis. Disomy 3, worse prognosis. And we started with a GEP, gene expression profile. That's what we use, and most centers in the United States use for the biopsies results to check the prognosis on these patients, on the patients. 2010, more information from the gene expression profile, saying class 1 or class 2 was not enough. Then it was the class 1A or a class 1B. Is that when PRAME started also in the late, yes, in the 20s. So I got PRAME in here too. So, we found about the gene mutations, and we have new medications to preserve vision. Now, I think it's important that we are talking about vision, because vision here, well, patients are alive. That's why we're concerning about vision. Patients are living longer than 40 years ago. In the 20s, well, the FDA approved the first medication for metastatic melanoma. And that was in 2022. That was the bentafusp. It was not for every patient, it was for a good percentage of patients with metastatic disease. New medications to preserve vision. And more in the 20s, we have the COOG, Collaborative Ocular Oncology Group. That's a group of 27 centers working together, analyzing, collecting data on more than 1,500 patients. And I'm going to show you the results from the COOG. Now, from COMS in the 80s until COOG in the 20s, this is almost 40 years. So we did not do a good job about working, collaborating together, trying to find answers to uveal melanoma. We have now also the NCCN guidelines, uveal melanoma subcommittee. So there are some guidelines, and I'm going to share this with you because this is important information for all of you. And future, little bit present, more the future about liquid biopsies. Doing a blood test, trying to know which patient will have or which patient will not have metastatic disease. Let's go a little bit over all this. These are the results from COOG. Look at the date, July 2024. And the PRAME was analyzed. It was another marker to know more about the prognosis. Is this uveal melanoma PRAME positive, PRAME negative? Let's look at that all together. So at the top, you see the normal melanocyte, and at the bottom is how it goes from a normal melanocyte, that's a cell, with pigmentation to metastasis. And you see different arrows there. Why? Because some patients, they have better prognosis than others. Some are intermediate prognosis, risk for metastasis, and some worse prognosis. Now, I want to be clear, and this is what I tell my patients. Class 1 PRAME negative is what we're looking for. Class 2 PRAME positive is more concerning. But what I tell our patients is that we're talking about higher or lower risk. Why? Because we've seen some patients, class 1, with metastasis. We don't know why, because there's some other factors. But this is the standard of care these days, that we do the biopsy, we get this result. Castle has been doing a great job, and we've been working with Castle for the past 15 or 20 years. PRAME is a new information, and at the top, you see the first mutations. The most common one are GNA11 and GNAQ. They're, I will say, the most specific mutations for melanoma. Why is this important? Have you heard of target therapy? Target therapy means that there will be one day some specific medications to work on these specific mutations. Okay? Now, let's talk a little bit about the National Comprehensive Cancer Network, the NCCN. As January of 2025, 88 NCCN guidelines features 228 algorithms that apply for 97% of cancers in United States and globally. There are 63 NCCN panels, more than or almost 2,000 panel members, more than 49,000 hours contributed by panel members in 2024. These are the members of the NCCN. And you can see that at least Dr. Salam and I were part of it too. What's the mission and the vision for the NCCN? Mission is to define advanced quality, effective, equitable, and accessible cancer care and prevention so all people can live better lives. What's the vision? Access to high quality, high value, patient-centered cancer care for all people, national and globally. I'm going to tell you at the end what I think about all this. The NCCN guidelines are the most thorough and most frequently updated clinical practice guidelines available in any area of medicine. The recognized standard for clinical policy in cancer care in the United States. Widely available, free of charge for non-commercial use. And this is my main point here. It creates the basis for insurance coverage policy and quality evaluation. Why am I saying that? Everything is great, but what we care about is this last point, because these are NCCN guidelines, 33 centers formed by panelists who are mostly experts in the field, setting the guidelines for the treatment of uveal melanoma. So nobody, meaning the last there, will say, oh no, this is experimental, this is this, this is that. Well, NCCN guidelines doesn't say that. So this is facts, these are facts. That's why the NCCN guidelines, they set the basis for the treatment. What about the NCCN guidelines for uveal melanoma? There is a subcommittee for that. And it's complicated, and you don't need to, you know all this. I mean, basically, it's including every single information we know about uveal melanoma. And it talks about diagnosis, it talks about prognosis, it talks about treatment, it talks about metastatic disease, clinical trials, et cetera, et cetera. So this looks simple, right? But every page, almost every page, has footnotes. but, if, but, well, in this case, in that case, et cetera, et cetera. So we are thinking about, we're trying to include all the possibilities for the patients with uveal melanoma with any features. Look at the treatment for metastatic disease. On the footnotes, and there is another footnote page. The NCCN guidelines for a uveal melanoma is like 30 pages, but this is people, medical oncologists, ocular oncologists, radiation oncologists, everyone. We meet 1 or twice a year for 3 or 4 hours, and we're discussing every single word you see in there. Present and future. Well, the Ventafus, the first medication that was approved by the FDA for metastatic disease. This is present. The second medication. Now we have 2 medications that have been, or 2 treatments that have been approved for metastatic disease. This one is 2 years ago. There is new medications that are being evaluated for systemic treatment. Now, you ask me, and I think this is personal opinion, okay? So this is not just how I see this is going to happen in the future. I think that in X amount of years, uveal melanoma is going to be treated with an oral pill. That's what I think that's going to happen. And everything Staller and many did with the plaques probably will be history. I don't know. I don't know when that's going to happen. But it seems that this is the way, because some of the patients that were treated with this medicine, this medicine decreased the tumor size almost 50%. So that some patients are responding all that. But again, this was not approved. What about the liquid biopsy? You cannot imagine how important this is, and it's happening these days, still at the research level, to take a sample for the anterior portion of the eye with a very simple procedure that can be done, we don't, but can be done in the office, taking a tiny sample, 1 drop, that was going to tell us there is DNA floating in the eye, DNA from melanoma. Also, we're looking for DNA in the bloodstream. Patient doesn't have metastases. We don't know, but we look for this liquid biopsy from the plasma cells of the blood cells, and we'll see if there is ctDNA floating in the bloodstream, and that patient may have sometime in the future metastases. So this is a very hot topic, and there are multiple centers working on this, not only for uveal melanoma, but other cancers. In summary, uveal melanoma is a team work. This is not a one-person show. That's not important how big the ego is of the treating physician. If that great physician, very knowledgeable, doesn't have a team behind him, her, to support the work, it will not be good. For us, the consultation starts when Jessica, our staff assistant, receives the referral from the referring doctor. The referring physician is important too. Some patients come long distances. Some patients, drive many hours, and we'll be working with the referring physicians. The staff assistant. If we don't have one that works well and we don't train, it's going to be a problem for the patient. Patient will be wandering around and where am I going, et cetera, et cetera. The technicians, they have multiple roles. Some of you know Howard. He's the technician who scribes for me. I call him my boss because I do and I go wherever he tells me that I need to go and whatever I need to do. He follows me, can I go? I ask him, can I go to the restroom? Yes, but you have 3 patients waiting. So this is the kind of, I ask him for, can I have a break, like my yogurt, lunch, salad, etc. Yeah, you can go now. That's Howard. You know that. Okay. They are going to evaluate the patient. The technicians evaluate the patient when the patient comes, and visual acuity, taking the history, reading the notes, putting the notes, et cetera, et cetera. The photographers, if we cannot document what we see today, we cannot evaluate how the patient looks in the future. So those roles are very important. Fellows and residents. This is an interesting topic. Why? Because we may have a great year, I call it a sabbatical, when, now we have what I do what Howard tells me, and now I do what the fellow tells me. So I have two people telling me what to do. We have one that is not good, then we have a tough year. So the team is important, everyone, ocular oncologist, the surgical coordinator. So in our case, it's Michelle. And since we got Michelle, she's like, give me more to do, give me more to do. I want to do more. She's doing everything. We cannot be happier when the patient tells us, thank you for making this stressful time a smooth one, because Michelle and Jessica and everyone I'm mentioning, they prepare the whole road for the patient. I'm naming them because these are the people we work with. Radiology, they are ready to, patient comes long distance, they're trying to help us doing the CT scans on the same day that we're seeing the patient. The radiation oncology, we have, there is a permanent communication, what type of plaque, what the size, what the doses, et cetera, et cetera. The medical oncology and her team. And it requires some hours to work together and find out, okay, what's best for the patient. And they are the ones who know everything about these systemic treatments. They teach us all the time. And when I put their clinical trials, and I mean in their clinical trials, that's where I would like to include industry. I will, because that's a partnership that we need. Without these companies, and I'm not going to name anyone in particular because I'm going to forget one, but without them, working with them, we cannot find all the treatments and everything that we are showing. You are going to hear today. I'll be happy, I think that's my last slide, I'll be happy to answer any question or start any debate with my colleagues. Thank you so much.
Can you talk to us about, kind of how you maybe decide the difference between someone who might need surgery, like enucleation, or someone who might need a plaque, and what that difference is? Because sometimes I hear there's this fear, we just got to take the tumor out, and how that decision making works.
So large blind. It's annoying to hear myself. So large blind painful eye, that goes for enucleation. For big tumors, it's basically based on the size. If the patient can have a plaque, we're going to do a plaque. We explain to patients that there is no advantage, and that's one of the things that COMS showed, is that there is no advantage removing the eye over doing the plaque therapy. So that's why the plaque therapy is the most common treatment worldwide. But it's mainly based on the size and prognosis, yes.
What do we have in new targeted therapies, and how quickly are they advancing? And are these targeted therapies for the eye or targeted therapies for the liver?
Not fast enough. Okay. I wish we had that like yesterday.
I see Aura nodding their heads. With uveal melanoma, we ran behind medical oncologists when they treated cutaneous melanoma. The first time I personally heard about immunotherapy, targeted therapy, was back in 2010 for cutaneous melanoma. Please, April, correct me if I'm wrong. And I show you that until 2020, we didn't know much. We didn't have much more information about uveal melanoma. So we are, I would say, almost 10 years behind the cutaneous melanoma. And it's reasonable because there are way much more people with cutaneous. So I've learned about BRAF and NRAS in 2010. And I've learned about GNA11 and GNAQ probably late, 5, 6, 7 years later. BAP1, that we've learned about that later on. So now, having said that, let's look for the good thing. The FDA has been very interested in uncommon disease, and uveal melanoma is one of them. So there is a large interest in less common conditions like uveal melanoma. So I think now we're going faster. So 3 years ago, no medication. In the past 3 years, now we have 2. So it's happening, and I think it's happening fast, maybe not as fast as we want.
But definitely faster than it used to, historically.
Definitely.
I mean, I've been diagnosed for just over 5 years, and you guys, I mean, I hope I can convey just how involved like I've been from the 4.5-year mark on, from that 6 months that I told you about this morning. The changes I've seen in the 4.5 years from March 2021 to now, it's insane in the best of ways. And so if you guys watch me on social media and you're like, how do you have such a, I don't want to say a positive attitude, but a hopeful attitude maybe? It's because I have a huge awareness from talking to doctors like Dr. Materin and from understanding just how far we've come, like he's demonstrated today. So what was your inspiration behind becoming an ocular oncologist who really focuses on ocular melanoma?
1992, I was a retina specialist in Argentina. There was no ocular oncologist in Argentina. And most uveal melanomas were treated by retina specialists. And I received my first patient, the first referral was 1992. I treated her with a cobalt plaque. And there was no ophthalmologist who was very interested in this topic. It's scary. And again, I'm talking about 30 years ago. And it started to be more and more interesting to me. And in 1996, more patients were coming. I said, well, I better know this much more than what I do. So I visited Wills for 2 weeks. And in 2 weeks, I've seen many patients, maybe more than anyone in Argentina, in their entire careers. 2 years later, I went to visit Wills again for 1 week. And that's when Dr. Carroll invited me to do the fellowship with them. So I said, well, let me ask my wife. She was in Argentina at that time, so I was like, it's not going to happen. So then she said, well, I told her, and we have 4 kids. And there was nobody ocular oncology fellowship trained in my country. And when Dr. Shields offered that to me, and my wife was like, well, we can come for 4 months. And I was like, Miguel, you're screwed. You're coming for the whole year. And that's what happened. So a few months later, we were here doing the fellowship.
That's amazing. Thank you. Thanks for sharing. All right, do we have any other questions? Oh, yes. We have one on paper. Thank you guys for following directions. I feel so happy. Okay, this is how my job is supposed to look, especially on the medical day. Okay, 50 ocular oncologists in the United States. Is that a rough correct estimate?
50?
50 as in 50.
I think that full-time is less than that.
Okay.
Right, Hakan? What do you think? It's 20, 30?
20 to 30? Okay.
To 30, full-time.
Okay. So what's the difference then between a full-time ocular oncologist who...
Because there are some, and I'm not saying they're not expert, but there are some doctors who treat other conditions like retina, and they do some retina, some diabetes, etc., and oncology is part of them from their work. in our work, it's full-time ocular oncology.
Okay, and this is, I guess, kind of a follow-up question. In that number, if there's, say, 20 to 30 full-time ocular oncologists, meaning you guys are the ones who treat the eye. And then April, like Dr. Salama, Dr. Moser, any of our medical oncologists, do we have any kind of a rough ballpark number of how many medical oncologists there are who specialize in uveal melanoma, just kind of in comparison?
That's a question for you, April.
In April, do you want to come up here and I'll let you answer on the mic? Sorry, I didn't realize. If it was going to be a quick number, I would just say, tell me the number. But if you have things to say, I want you to be able to say them. Thank you.
Thanks. So it's tough because, uveal melanoma is a rare cancer. And for a medical oncologist, it is difficult, I would say, to exclusively focus on ocular melanoma. Certainly there are medical oncologists whose practice is predominantly ocular melanoma, especially at very large centers, places like MD Anderson, Memorial Sloan Kettering, that see large numbers of melanoma patients. But even just taking a step back, there are not that many of us that focus on just melanoma. I would put that number, probably double to triple but I think there are less than probably 100, medical oncologists in the country who focus on melanoma. And then most of us certainly focus on ocular melanoma as a subset of that practice. But even in kind of ocular melanoma specialists, they will tell you about a half to 2/3 of their practice are patients with ocular melanoma. For us at Duke, because of the fantastic work of Dr. Materin and Dr. Maniar, Duke is such a major, referral center throughout the Southeast that it's about 1/3, we think, of our patients are ocular melanoma patients. So we kind of focus on it within the context of a dedicated melanoma clinic.
Okay, I think that helps. Dr. Materin, do you have anything to add? Okay. All right. This is the last question, and then I think we're going to go ahead and take a break for the day. If you guys do have more questions, especially pertaining to anything that, a question that Dr. Materin might answer pertaining to ocular oncology, we will have the next session. We're going to be continuing talking about the ocular melanoma phase, ocular melanoma after treatment. That's going to be our focus for the next session. But as our final question, do you both agree or do you both believe that it's important in ocular oncology and in medical oncology for patients to see someone who specializes in uveal melanoma and or, ocular melanoma, like an ocular oncologist versus okay, I'm going to break this question in two, sorry. Do you think it's important for a patient who's being treated in their eye to be treated by an ocular oncologist versus, say, a retina specialist who also, a retina surgeon maybe, who also treats ocular melanoma, but it's like not his primary or her primary?
We're live, right?
We are live, yes. No pressure.
So, definitely ocular oncologist.
Okay.
But there are some retina specialists who were well trained.
Okay.
And they are up to date information. Mm-hmm. And that's okay to treat other conditions.
Okay.
So I cannot say that only ocular oncologist. That's not fair, because you may have someone who was ocular oncology trained, and it's in an area that there are few patients with ocular melanoma, and they need, they need to go to the supermarket, and then,
Yeah.
So there are people not full-time ocular oncologists. There are retina specialists that they are capable to treat this condition.
Okay.
Yes.
All right. I love the answer to that question. And I'm going to have Dr. Salama answer the question as well for the medical oncology side, with the caveat that we are just going to let her give a teaser because she's going to be talking more about this at 11 a.m. in our track 1 session.
Yes. So I will talk about this, touch on it a little bit actually in our session, but completely agree with everything that Dr. Materin said. I admittedly am biased, But I do think it's important to at least have a consultation with a medical oncologist who specializes primarily in melanoma and then uveal melanoma to get kind of a general overview and education and guidelines. I acknowledge, though, and we will talk about this a little bit, about, we're not close to some people. We're working on ways to use technologies, things like telehealth, things to make it more accessible for patients to come get their follow-up. But we also acknowledge that that's just not realistic for a lot of patients. What I do think is important is that they are seen by a medical oncologist as part of their surveillance. I do not think, for example, being seen by a primary care doctor, just ordering a scan. We are looking at our own scans. We are kind of having consultations with our radiologists of any questionable findings, and that's really out of the scope of a primary care doctor's practice. So I do think, partnering, sometimes it's that teamwork, that partnership with a medical oncologist at an academic center who maybe has a more subspecialty focus, and an oncologist, perhaps practicing closer to home.
I'm not going to be that nice. I think that medical oncologists must have experience in treating uveal melanoma. If the medical oncologist does not know what class 1 PRAME positive is, so that's not the person to do the follow-ups or to monitor these patients. So I'm not talking about specialists, I'm talking about people who are informed about what to do, and they have experience about the new medications, about the new treatments, and about the prognostic factors, et cetera, et cetera. So that has to be a person with experience in the topic. And by the way, if you're shy, we can answer questions later in person. So we're going to stay here all day.
Thank you. Thank you, Dr. Salama, Dr. Materin. Let's give them a round of applause.